So our first speaker is our keynote speaker for the summit. Dr. Mike Watson is in the back and will be making his way up here. He got his master's degree in medical genetics and his PhD at the University of Alabama. His PhD is in physiology and biophysics. He's held many different positions within ACMG on a voluntary basis, leaders of groups, work groups, et cetera, and he's been executive director for several years. He's also been the project director for the National Coordinating Center. You'll hear about some of the national efforts going on in his talk, and that's funded by HRSA, as is NIMAC. He also is the leader of the Newborn Screening Translational Research Network since its inception in 2008, and that's funded by the National Institutes of Health. And more recently, he is the lead on ClinGen, which is a project aimed at looking at the clinical relevance of genes and what they mean to the patient, what's the medical outcomes of the mutations in the various genes that are being sequenced like mad these days. And that's also funded by the NIH. He has many different publications, and he's going to talk to us today about some of the national efforts to bridge gaps in genetics. Mike?
All right, thank you. Good morning. So this talk changed last week. I was going to actually be able to talk a little bit more specifically and in more detail about some activities we're doing, but then all of our funding opportunity announcement came out at the end of the week. And given that once those things come out, the folks at HRSA really can't talk to us about them, I decided to build back into this talk more stuff about where the next generation of what has been the regional collaboratives is going to look like, and what the grant statement of work looks like that we'll all be responding to over the next 8 weeks, is it? We've got maybe? Yeah. The theme of the meeting obviously actually fits really well with the funding opportunity announcement that's come out, because it is all about gaps. So what I'm going to talk about today are I'm not sure whether there's bigger gaps than there are solid stuff for us to anchor ourselves on. At least if we're dealing with gaps, we've got plenty to work with. I'm also going to talk about the NCC's assessment of news service support models and results, because that was one of the things we were charged with in in what was our second year of our last round of this grant, the current year. We got that in time, at least, for folks in the federal agencies to think about the things that the regional collaboratives actually thought were going to be important in trying to fill gaps and address some of the issues of getting genetics and genomics better integrated into healthcare. In the NCC, we partner up with the National Genetic Education and Consumer Network, and I think you'll see there's a lot more focus really on the consumer side and the current funding opportunity. I think, is it anybody here from the James? Yeah, so I'll show a few of the things that they did with us in developing our sort of assessment of the system and what might be done to fill gaps. And James will be available because they've got a ton of data, as do we, from our assessments, the vast majority of which we really can't include as slides, or y'all will be rendered unconscious. I'll also then talk some about, because we are the NCC currently, I'll talk some about some of the work group activities, specifically those that do relate more to the funding opportunity that just came out. So when you all start meeting today and tomorrow to talk about your own response to the funding opportunity that's opened up, you'll have a good sense of what we're able to do in partnership with you if we were lucky enough to successfully compete for the grant. We all go in competing, and nothing's guaranteed for anybody. So we'll hope it all goes well and we get to continue to work together. And then I'll talk about some of the other activities that Michelle mentioned when she introduced me. Newborn Screening Translational Research Network obviously could contribute some of our activities to the activities of the regional collaboratives in the NCC. ClinGen, I'm not foolish enough to take the lead on that many projects. I'm a co-PI in ClinGen. I don't lead it. I partner up with Geisinger and University of North Carolina, with UNC leading that project among 3 groups of grantees and the NCBI that are participating in the ClinGen project. So I'll touch on some of those activities and where they relate to gaps we might be able to fill. So, as I said, addressing the gaps is really what the funding opportunity announcement's about. You know, right now we're pondering whether we're going to make it across the gap because it's pretty big. There's clearly a lack of scope of practice as to who does what. This happens commonly in areas of medicine where a lot of what you do is cognitive. We certainly have tests that are fairly discrete, but it's a very cognitive field based on, with just thousands, 5,000 to 7,000 rare genetic diseases, most of which is frankly based on expert opinion. Which really is one of our challenges, because that means we don't have enough statistical power that somebody who hasn't been trained in genetics can look at our data and go, okay, that's obviously what I should do. So they're far more dependent upon these links into expertise, and we'll have to figure out that as we develop the next opportunity and figure out how we're going to bridge across these gaps. So although the title was assigned around the gaps, I will give you some information on the NCC and its activities. So I guess one of the good news aspects of the funding opportunity that's been opened is that the regional structure is going to remain the same. You don't have to figure out how to integrate a new state or transition a new state out. However, you do get to rebrand yourselves, because it's going to be the regional genetics networks in the future. Which is always an interesting challenge to go about rebranding an entire system. So I'm going to talk a little bit about the last 2 years. We were put on a 2-year cycle in the NCC to get us aligned with this next funding opportunity, so that the NCC, what has been the regional collaboratives, and the NGECN will all be competing at the same time and have similar lengths of their projects, which is, I think, important. It allows us to be much more certain that when we partner up with the regions, we're actually going to be there for the entire time that they're there. And it's been difficult with them on a 5-year round now and us on a 2. So hopefully we'll have a little bit more stability. A lot of the work we did was actually restructured this year. We run a lot of work groups that are multi-region or national in their focus. But we were asked to really start paying very much closer attention to the access issues of underserved populations, and even served populations. There's a lot of access issues that you'll see from some of the materials we developed and that the Genetic Alliance developed under the NGECN. We were charged with providing infrastructure that strengthens communication and collaboration, part of why I'm here, and why we have lots of conference calls among all the work groups and the PIs, project directors, and project managers on a monthly basis. And we implement a national genetics education and consumer network. So the year has been interesting because we've been trying to get as much information from as widely as we can, get all the regional collaboratives' perspectives on where this program should go, so that we could synthesize it into what we thought was the kind of structure that was going to work for the gaps and problems that have been identified in delivering genetics and genomic services. And we knew there were going to be tough decisions ahead because we didn't really know exactly what the funding opportunity was going to ask us to do. We have lots of meetings with HRSA and the Genetic Services Branch folks, and we certainly know what their interests were. They were clearly in much better data about access, who are we impacting, and those sorts of things. And that's actually a difficult problem. In many ways, it brought corn down, which was the Council of Regional Networks. For those of you who aren't as old as me, that's what preceded the regional collaborative system. But it had a lot of data collection, and at that time, our systems really sucked for getting data. It took a lot of manual labor that was actually imposed upon the regions, and it was actually, I think in the end, brought the system down because it just couldn't only provide data. Was the only thing they had the funding to actually do. All right, so I'm going to touch some on that what we did for most of the year, which was looking at these regional service and support models. We really wanted to look at what was out there, what systems were being used to fill gaps by different kinds of programs. So we went through a rather long exercise, not long, deep exercise that took 8 months because we had to get it done fairly quickly. We did national surveys both of the professional community and of the consumer community, and then developed recommendations for components of models that would ensure access to services for the underserved populations. So I'm going to show you a few things from the NGECN analysis and surveys that were done. The number one issue that they identified from the consumer side in the availability and access to genetic services was a lack of healthcare providers with knowledge of the genetic condition. So clearly, and certainly at the end of our exercise, all the workforce issues were at the top of the pile, because they are fundamentally why we have to get so many others to take on a role within their scope of practice, to certainly find patients who need genetic services, hopefully deliver some of those themselves, but minimally be able to refer to those that actually can take care of whatever the problems are that patient has. The consumer side found that it was very hard to know where to find providers with knowledge about a specific condition. Not surprising if you've only got 5,000 to 7,000 of those to deal with. And that the biggest barrier they identified was lack of providers with expertise in a particular condition. I'm only going to show one slide from the many that have been put together by the Genetic Alliance that report on their surveys. So I'd recommend, as you begin to think about what your region might do, that you get, James, is your report widely available, or is it something they can just communicate with you to get more of the details?
I think we had sent out to all the regions internal report. It's submitted for publication, but it hasn't been published yet.
So yes, you have it. It's gone to the regions. It's awaiting publication. So just to give you a sense of it, this is one of the summary slides, the top barriers that reported by region. Unfortunately, your region is in the darkest blue on a black background that makes it very hard to see. But I couldn't figure out how to change the background to white, so I surrendered, because every time I did it, everything changed to white across the entire set. So the number one barrier by region was the lack of providers with expertise in particular conditions. And you can see that at the top. It's pretty balanced across regions, and is clearly the major issue for the consumers. Then there was a whole gamish of things that were in number two. The number three was the availability or wait time to get an appointment in a genetics clinic. And then the cost was their number four issue. And obviously, there isn't a whole lot we can do about cost. And there's an awful lot about our healthcare system that makes our jobs difficult, that's hard for us to impact. Some of the other issues that consumers identified was that the very first thing they do is they go to an internet search of whatever it is that they've been told to worry about. Individuals and parents really want to help understanding the condition and where to find relevant resources. They're most comfortable receiving information from either fellow parents, individuals with conditions, or from care coordinators. There's a lack of social and emotional support within our system, and they identified telemedicine, even though I don't know how many actually might have experienced it, but they clearly identified that as something that would relieve a barrier of distances to academic medical centers and things like that where most of the geneticists operate. So we looked at 8 major models as we were developing this. Some of these were quite unrealistic. I mean, the CF Foundation has a spectacular system of clinics and data collection. They also got $3 billion from the clinical trials that were done for drugs that became available to treat cystic fibrosis, because they funded a lot of that and struck a really nice deal that put them in a really wonderful place that none of us are in, nor are the other 4,999 diseases. So despite that, we identified parts of the various systems that we thought were applicable. We looked obviously at our own system of the regional collaboratives, clinical support centers for workforce capacity. We looked at Project ECHO and things that provide education. Regional patient engagement centers, public health models were reviewed, quality improvement models, regional clinical support networks for things like hemophilia and other of the resource centers that HRSA sponsors, and genetic service data centers, and could find pieces that might be applicable to the gaps we saw in genetics. from all of those. So we obviously ended up with what was a recommendation of a hybrid model that took some of the best from these various programs and tried to fit it in to the realities of the kind of funding we have available within this system. The funding looks pretty much stable from the last round to the next round. So I think you can anticipate similar levels of funding should you be successful in competing. Some of the major messages that when we combined both the Genetic Alliance's consumer surveys and the surveys we did of the professionals, the major recommendations that resulted from all of that were that consumer engagement was a key element in the formation and functioning of future genetic service resource centers. And you'll see that reflected in the funding opportunity announcement that came out last week. And that there's a significant level of uniformity is going to be needed across the various resource centers, regional collaboratives, regional genetics networks, in order for us to be able to take that data and aggregate it up to a national level to really be able to see what kind of an impact we're all making. It does lead us to a bit more uniformity in the way we define certain things that we're collecting data on and building the systems to collect that. We recommended a genetic services support model that was a hybrid of a couple of the models. The model would have a primary focus on promoting efficient practice within the genetic centers themselves, technical assistance for telegenetics, technical assistance for authorizing genetic testing, something that is impacting clinics and service providers all over the country, as so many of our tests and services are not under coverage policies that allow us to immediately bill. Lots of pre-authorization to justify why we want to bill a particular service. The second major recommendation was regionalized structure. We thought that there's enough variation in across the country and that the kinds of gaps we identified were really related to some of that variability across the regions, and therefore that a regional system similar to what we had was going to be important. That there needed to be central coordination around some of the key functions. We've been taking on a role of program evaluation over the last several years that's ratcheted up considerably, and I think is going to go up another level in the next round. And then functioning support centers with healthcare delivery systems and the role of public health, and how do we bridge across those parts of the system. Providing non-genetics provider education was identified as an important area. Data collection to inform us of whether or not what we're doing is making any difference. Addressing the lack of mental health services, not a problem unique to genetic services, certainly. So one that we'll have to figure out not only what we can do in genetics, but what is being done nationally to deal with mental health issues across the board. And then support for increasing the number of physician geneticists, that entire workforce issue that requires us to push more work out and enable other parts of the system to get more involved in genetic services. So 3 RFAs came out last week, I'm sorry, I wish it was last year, but last week. HRSA-17-082 is called the Regional Genetics Network. That's what the system will be called instead of the regional collaboratives. There's another RFA that came out, which is 083. That is now spinning out the National Genetics Education and Family Support Center as an independent resource center and is being competed individually. And then the National Coordinating Center for the Regional Genetics Networks. That is the one that has not come out yet, so I can't guess what it's going to say, outside of the fact that if you read 082 for the regional networks, there's a number of places where they talk about relationships between the networks. Similarly, in the Genetics Education Family Support Center, there are relationships identified between a national coordinating center and those projects that give us some sense of what's likely to be in the NCC RFA when it comes out. So 082, this is the opportunity that the regional collaboratives are going to be responding to, and anybody else who wants to compete for a regional collaborative. It really has sort of 4 primary goals: improving health equity and health outcomes in individuals with genetic conditions, reducing morbidity and mortality of genetic disease, and strengthening and improving the quality of coordinated follow-up and treatment, and that this would be done within a current regional, something similar to the current regional structure. The purpose that's defined in the grant opportunity for the regional genetics networks is to link medically underserved, meaning impoverished communities, rural communities, groups that are known to be medically underserved, and those sorts of populations to genetic services, which is an interesting challenge we'll all be facing. Implementing quality improvement activities to increase this connection and connectivity between genetic service providers and these medically underserved populations. Implementing evidence-based innovative models of telehealth and telemedicine with a focus on clinical genetics outreach, and providing resources to genetic service providers, public health officials, and families. Now, there are 14 specific work requirements for the regional genetics networks. 3 of them are sort of administrative things about having steering committees and running your regional meetings. There are things about technical assistance that are identified in the funding opportunities. If you look within that 082 funding opportunity, you will see one that describes or provides the links to a technical assistance webinar or conference call that HRSA will run for anybody considering applying for or responding to these funding opportunities. So I'm just going to touch on these non-administrative ones quickly to give you a sense, and then after that I'll start talking about things that we've been doing and that we're doing now that can begin to address some of the specific issues identified or that we're all going to be addressing in the future. Excuse me. So we're to develop a regional web-based genetics resource for primary care, public health, patients and families that will map the availability of genetic services and resources to the region. Implement strategic plans to identify and link underserved populations in each state to providers. And then with the NCC and other entities, reduce duplication, develop, disseminate educational resources for primary care providers that increase the ability to identify patients that need services, to refer them where appropriate or where that assistance of a primary care provider might be needed, and to use genomic information. Partnerships and contracts with regional academic medical centers are going to be developed, health systems, public health, in order to better coordinate access for these underserved populations. Technical assistance for primary care providers and other specialists on health information technology, things like telehealth, mobile mHealth kinds of infrastructure that is really a critical part of the precision medicine initiative that is rolling out right now. Facilitating telegenetics outreach services in the regions, and communicating strategies to share information success barriers in and among regions. Promoting family and patient engagement as partners in care through the regional genetics network involvement. Collaborating with the NCC on evidence-based quality improvement to connect these underserved populations with clinical services, provide resources to the genetic service providers, primary care and public health genetics to accomplish that. I think the good news is that you see some repetition. You may think I already said that. Fortunately, it was one of the things we recommended or recommended about kind of infrastructure that was going to be needed to address gaps that the regional collaboratives had already realized. So there, fortunately, I think is a reasonable alignment in what we thought was important and what HRSA ultimately is asking people who respond to this particular grant opportunity to do. Collect regional genetics network data and submit to NCC. That'll be an interesting challenge because obviously we don't want to limit our ability to do lots of other things, so need to figure out what kind of data is available, how can we readily get it and communicate it without overburdening ourselves and the regional collaboratives with manual labor to develop this kind of data. And then partner with stakeholders addressing genetics and genomics, which is just about everybody right now. All right, so now I'm going to talk about some of the ongoing work that we're doing to address these new requirements of this regional genetics network. Some of which are things that we've actually been doing for several years. They're challenging projects and they required us to gradually ramp up our activity in them. Our evaluation work group will obviously have to continue because part of the data collection is similar to what we've been doing. Who are we impacting? Are we improving access to general populations or to the underserved populations? Coordinating care is increasingly important, and it's always been that way in genetics. I think almost everything I end up finding myself doing at the national level looks an awful lot like what I did when I was at Washington University in St. Louis. Our patients are multidisciplinary. When we were seeing a patient in our division who had a multidisciplinary problem, we met with all the other specialties that were going to be delivering care to that patient group in order to be able to align our messaging, because it's very easy for one specialty to start giving mixed messages to patients that the other one isn't giving. So we were constantly trying to keep ourselves aligned in our communication, and that's very much what happens at the national level, is keeping ourselves aligned with other specialties, with other non-genetics trained providers, in the kinds of things we think they should do with our patient populations. Telegenetics is an activity that we've been actually involved with for quite a number of years. Sylvia Mann has been leading that with Lori Dean from Oklahoma, from the Heartlands Regional Collaborative. It's actually ramped up considerably. They're now at the level where the system has become relatively stable. There's reimbursement that seems adequate. There's equipment available to people, and now they're starting some actual training within various regions of the country to get counselors and other genetic service providers up to speed, and looking at ways to get new residents and trainees in genetics trained in these areas so that when they come out, they're actually aligned rather than having to train the person who's already in practice. The work group is going to be encouraging all the regional collaboratives to develop projects in the coming months around telemedicine and genetics. And I think we're pretty well ahead of the curve because telegenetics is clearly teased out in that regional genetics network opportunity. Healthcare access and financing, not an easy challenge in our healthcare system. Lots of small groups, consumers, coverage of genetic services and integrated delivery systems are meeting, doing small projects and solutions for further exploration of the issues. It's one of the advantages of at least we thought we got it right when we put out our own sort of recommendations of where the gaps were and what we needed to do, that allowed us to actually really ramp up a few of these projects in anticipation that we did guess at what the gaps were and that those would be things that would be asked of us in the next round. So I do think we have a good head start on the system. And then more collaboration with APHL and ASTHO. It's not just APHL and the laboratories that do newborn screening. They probably are going to get increasingly involved in genomic screening in the population over the next 5 years of our grants. Lots of support materials are going to be needed. As we said, there's a lot of problems in the education of non-genetics trained providers and their ability to take on more of a role in genetic services. So these documents that we've developed, like act sheets, that are sort of something that guides somebody through a 2-week period of their life, where they've got a patient of a type they have never seen in their practice before. They need a really tight point of care type of education. And that's what the act sheets were designed to do. And we find them incredibly highly rated within the pediatrics community and among family physicians. However, what we find is that none of them know they exist. Once they know they exist, they end up in the 90-95% sort of rating of their utility to their practice. So clearly we have to figure out how to make those more widely available and known. We're finalizing a whole set on the lysosomal storage disorders, several of which are in pilots now, multi-state pilots for newborn screening. We're finalizing secondary findings act sheets around genomics. If somebody asks for a genomic study in a cancer patient and finds out their patient has a risk for cardiovascular disease, it's not going to be within their expertise. So we thought that act sheets were appropriate in that scenario to guide somebody with what to do with a patient who has a risk factor for which they are not the specialist directly involved. So it's not unlike the primary care provider's position in newborn screening, where they're forced into the system to manage patients, though may not have much background with the particular conditions. Working with our larger ACMG committees on non-invasive prenatal, we're developing act sheets that support all of the results that can come out of non-invasive prenatal screening, which is pretty rapidly expanding, and then developing PCP education act sheets with the Genetic Alliance. So act sheets, I think everybody's seen those. I'll zip along for fear of running over time. You're too close to whack me if I get out of time here. Other activities, we've been running a advocate leader program where we bring leaders of advocacy groups across the country to our annual meeting and sort of walk them through our annual meeting, provide opportunities for them to ask questions about things they've heard. And it's been a very nice program. A lot of folks have come out of those, become involved in regional collaborative activities. And what I don't tell them is that they actually become people I can identify when we're looking for consumers to bring on to activities we're involved in. Community conversation is going to take place in Phoenix at the ACMG annual meeting this year. It's on reaching minority populations, genetics in the frontier communities. Usually on Tuesday evening. I think the timing is still being sorted out. It's open to the public. It's not just for meeting attendees, and it's an open forum that brings a topic of interest to the ACMG audience, and many of the regional collaborative people do both the ACMG meetings and their own activities. So, science is moving really, really fast. Newborn screening is moving fast. As I said, we're now, through the Newborn Screening Translational Research Network, sort of administrating 3 major multi-state pilots, and I'll talk a little bit more about those. But I think in the next 5 years, watching for the potential expansion of newborn screening is going to be a pretty important issue to get ahead of, because as we look at what's sitting on the cusp of needing that big population study, we're going to have to figure out how to do these much more efficiently than we have. There's no doubt that right now we have, we started a Pompe disease pilot, we started an MPS 1 pilot, and now we're about to roll out an X-linked adrenal leukodystrophy pilot. The reality is that from an analytical perspective, those could have been easily combined and multiplexed at much less cost than doing these one at a time and the associated cost for that. So I think looking at our technologies that are available and how are we going to multiplex pilots, because if you think this is where we were in 2015, fairly modest expansion of what we had recommended back in 2005 as the uniform panel for newborn screening. However, we know that there's at least 30 conditions sitting out there on that launch pad needing what could be a very expensive pilot study. They tend to be very large populations because of the rarity of the conditions that we're screening for. When we did the SCID, severe combined immunodeficiency pilots across 6 or 7 states, we're now around 3.5 million babies that have been screened. But we had to get out to about 2 million before we were comfortable even with the manuscripts describing what happened with long-term follow-up of those patients. There's a lot of evolution of consent. Sometime probably in the next 2 months, we're going to see what OHRP is going to be recommending for the changes in the common rule. I'm not sure where it's going to go. They seem fairly comfortable with the draft they had put out until the National Academy of Sciences came out with a paper saying you got it completely wrong. Go back to the starting board on this entire idea of how to get better consent for patients. I know certainly many states appreciate the difficulty of getting consent for pilots, which could be considered research. We know how insane it is to be waiting for the Secretary's Advisory Committee to make a recommendation to add something to the recommended panel on relatively weak pilot data, and then us being funded to do an implementation pilot when we know we need a lot more data on the front end before the Advisory Committee makes its decisions about what really is appropriate for newborn screening. Because it is difficult to take something off the panel once it's on. There's no doubt about that. But I think the reality is we're going to have to find some way of having provisional approval and a later decision as the numbers build up as to whether we got it right. It's not different really than what happens under the Orphan Drug Act, which says, you know, these are rare diseases. We think we see enough data to say this therapeutic or this treatment should be made available, but we're going to require phase 4 post-market surveillance to make sure that what we thought it looked like is really what it looks like. And you know, I can't imagine with the population sizes we're going to need that some other approach to pilots is going to be needed. So what does that expansion look like? I'm going to zip through this. This is a partial list of conditions sitting on that launch pad waiting for the big pilot. They all think they have interventions in place that could make a significant difference in that patient's outcome. Just this group here would get us up into the neighborhood of 74 primary conditions in newborn screening. Well, once you take just the lysosomal storage diseases, there must be 45 to 50 of them now, many of which have therapeutics either available or in clinical trials. This is an entire group that is really on the launch pad for those multi-state pilots. Adrenal leukodystrophy is already in pilots. They're just starting to do their data collection, but it's not just X-linked adrenal leukodystrophy, it's Zellweger's disease. It's the carriers of adrenal leukodystrophy. So we, you know, even with our primary analytical targets, we often have other conditions that are being identified. Creatine defects, I think the Secretary's Advisory Committee was looking at GAMT deficiency recently as to whether it should be put on the RUSP. As we think about these creatine disorders, there's at least 4 other groups of conditions that fit under those analytical biomarkers that are used to identify GAMT. Now we're up over 100 conditions in newborn screening. So I think you get a gist of this problem that is likely to get more and more evident over the next year. The system, NIH is able to fund one and maybe start another near that as that one is beginning each year. So clearly, I think we're going to be looking within the NBS TRN. We're going to look hard and work with other groups to think about what does a system really look like, not just the newborn screening laboratory is part of this problem. The diagnostic community has problems with the patients coming out. When we have low positive predictive values, they get clobbered because we have a workforce deficiency. So we're going to have to figure out what the system looks like, what is the best way to introduce new conditions into newborn screening, hopefully define a broad system that represents everybody involved in this process and make it widely known so that Congress is the only one that can dedicate funding to fixing a problem of this magnitude for a program the public clearly values enormously and has a lot of clinical value. All right. Standardization was one of the things teased out in the recent Regional Genetics Network. There's a lot of folks that get involved in standardization of services, standardization of how we say what we do when we deliver services, all the way down to individual phenotypes and the data dictionaries that allow us to aggregate data far and wide from patients all over the country to better understand a disease. You know, what's one of the things that we get in genetics is a lot of variation in severity, penetrance not clearly understood until we go to newborn screening. I can't think of a condition that actually turned out to be what we thought it was when we recommended to go into newborn screening, because really we're dependent upon data about people with disease and think that tells us what the disease is. But that is a strong ascertainment bias. We really learn when we get to newborn screening about how many people may or may not ever be affected by that disease, and a much broader range of severity than we anticipated. So we have lots of standardization to think about. ACMG gets very active in standardization. I'm going to zip through some of these just as examples, but I think we're going to have to figure out ways by which we both work with the regional collaboratives and our own membership to figure out where do we need guidelines to guide people, where are the problems that perhaps our committees can begin to fill. We've been actively involved in standardizing how we interpret sequence variation. That was critical to ClinGen because it's based on data sharing broadly and having standards by which we We can describe gene associations or decide whether a variant is pathogenic or not. We put out that guideline both for the laboratories because we knew there was an enormous amount of variation in what they were calling as pathogenic or benign. And you'll see that that's applicable, while applicable to a relatively small 10, 15% maybe of patients with a particular condition, it becomes a significant problem if you're not one of the 80% of patients that has one of the 15% of common variants in that gene. A small percentage will have the vast majority of the variants in that gene, and there may be only 1 or 2 people that ever had that variant. And I'll talk more about that. Now, I don't have time to really talk about our recommendations for pathogenicity of variants, but there are various biological and genomic features that can help a laboratory make determinations of whether or not a variant is going to be pathogenic or not. They're anywhere from strongly pathogenic, likely pathogenic, uncertain, into the benign categories, and it's going to take data sharing to sort those out. Let me zip along here. I'm going to come back to that when I talk a little bit more about ClinGen. We've put out guidelines recently. One came out just over the summer on non-invasive prenatal screening. While it's been historically used in aneuploidy detection, it's pretty powerful for microdeletion testing as well. And we anticipate a fair bit of that coming on board. Most of the microdeletion syndromes are very rare, so there's not much replicated data available. So our recommendations really were making patients aware of the fact that not only the trisomies are available, but also deletion 22 can be made available in in prenatal screening environments. Sort of the guts of our recommendations recently are that everyone should be offered non-invasive prenatal screening. No calls are actually at higher risk of aneuploidies than is the general population. So that needs to be noted, and those patients may need to go to other types of screening or diagnostic testing. Copy number variants are emerging, and deletion 22 at least being the most common deletion syndromes in the population, had enough data available to make specific recommendations about it. And the diagnostic follow-up for the screen positive, because it was clear that this outer layer of the placenta that is releasing cells, it's like the direct analyses we used to do in chorionic villus samples. It's that outer trophoblastic layer that is what's getting out into maternal circulation. So all the problems we all had with CVSs done by direct, where about 10% of the Down syndrome patients identified turned out not to be. It was a confined placental mosaicism. Could have easily been anticipated for non-invasive prenatal because that outer layer of cells is the one sloughing off a lot of DNA into maternal circulation. Genomics is something we're charged. When you read the RFA, you'll actually be amazed at how many interest groups there are, or stakeholder groups there are in genomics that we're charged with helping become educated about this. Clearly, there are so many that we'll have to find some central ways of thinking about that problem and not be dealing with them one-on-one, though where we have to, I suppose we will, because it is in our work requirements. Importantly, clinical standards are not available for most of these. Practice guidelines are not available for most of them, so it's going to be a challenge. We've been putting out recommendations in the area of genomics about reporting secondary findings. We thought that there were a handful of genes and conditions which were actionable and which, if identified in the course of a genomic study for a specific reason, could be made available to families. Critically, what hasn't happened I think that is really important is that data needs to be aggregated nationally, because it actually becomes the pilot for genomic screening in the population. It's a relatively unbiased group. They come in for cancer. They're found to have a cardiovascular risk. So it gets rid of that kind of ascertainment bias around their disease and makes them a more general group, hopefully, than would be available in a sort of a clinical population. We have lots of international partnerships we'll be able to take advantage of. In the data sharing world, numbers count. So working with projects like the Global Globin 2020 project that is about 100 countries across Latin America, Sub-Saharan Africa, out through Indonesia, in the malarial belt. Thalassemia risk countries are becoming involved in both learning genomics and applying it to their populations, because clearly they're going to be helpful in us understanding how to interpret results for people from specific ethnic groups in this country. There is enough variation among groups in which panels of variants are going to be important, that we are going to have to get somewhat population specific, and dealing with those international projects that do this can give us data important in the United States. The Global Alliance for Genomics and Health is also becoming increasingly active internationally in trying to develop data around genomics. All right. So, as I mentioned, I think primary genomic screening is on the horizon. Incidental findings or secondary findings are guaranteed to be identified in those kind of studies. The real question is, how many people can we put out for follow-up in a system? So we've been making recommendations that really try to control what comes out, what could come out of genomic screening, and thinking about it not that much differently than we do newborn screening. The payers will go bonkers if we actually put out every uncertain variant and try to follow those clinically, because there's a ton of cost to be had. So we're trying to set the bar very high at levels where what you know about the gene and its association with the disease ought to be pretty definitive. There was a paper actually in Genetics in Medicine back in June or July that I think is actually very important. It's about hearing loss and identifying causes of hearing loss in those who don't pass their newborn screening hearing loss test. Excuse me, I knew I would go dry. So historically, what people have done is every time a patient's identified with hearing loss and a genetic etiology, it ends up on a panel of things tested. And in reality, if you're in an asymptomatic population, a lot of that can go away. And if you look carefully at whether or not you know the hearing loss is associated with the condition because it's just a case report, or if it's because there's a lot of patients with that and it's known to be a part of a disease, you can have a qualitative difference in how well you understand that association. So we're pointing at definitive associations, very strong associations between genes and conditions as those that should be in screening, and variants that are known pathogenic or likely pathogenic, which controls what comes out of the system. So I think as we begin to think about genomics, it's going to be thought about very similarly to newborn screening. And we'll have lots of work to do with our public health community as that begins to move into medicine. I'm going to skip the penetrance problem because I mentioned it already. I want to quickly touch on ClinGen because it actually, I think, is the place where we'll be able to enable a lot more people to participate in communicating results of genetic testing. You know, when you have when you're one of those variants that's only been seen once in a population, it's hard to interpret, and most practitioners won't be able to apply the expertise to the interpretation, nor really have a detailed discussion with a patient and family about it. They may be able to say, yes, this is probably bad for you, but that it's going to be incredibly difficult for them. And ClinGen is really aimed at a couple of critical questions. Is this gene really associated with disease, which is basically clinical validity? Is the variant in that gene causative? So is it pathogenic or not? And is the information actionable? Is there clinical utility to having found them? With an ultimate goal of growing a genomics knowledge base and improving patient care through genomics. We do lots of standardization. I think if you look at the Precision Medicine Initiative, standardization is going to be critical. You can't go into an EMR all over the country and pull out data if people haven't interpreted the same variant in the same way, because you'll be pulling garbage into central databases and not be able to make sense of it. So getting that kind of uniformity and standardization is going to be important because we are moving into an area where it is broad data sharing and lots of collaboration to build the knowledge bases we're going to need. So centralized databases like ClinVar, eventually over time, as we curate more and more of the genome, we can partition ClinVar into a part that has been clinically curated to separate it apart from the garbage part, which is sort of voluntary data submission that hasn't been evaluated and curated, so that we really have something that supports clinical practice. We have groups assessing actionability across all the genes we analyze and developing machine learning algorithms so that once we have enough data and know where it's coming from, as that data grows, we can build machine learning tools to continually update sensitivity, specificity, those kinds of parameters. So right now in ClinGen, we're really running, it took us a couple of years to standardize, to build our systems for infrastructure and data collection. So now we have a couple of groups, clinical domain working groups, that really is what the Geisinger, UNC, ACMG part of ClinGen deals with, is the clinical curation of the genome. So we have groups working in cardiovascular disease now, inborn errors of metabolism, germline cancer, pharmacogenetics. We just are rolling out neurology. I foolishly got to do somatic cancer because I was the only one who had run a cancer lab among the PIs, and wish I hadn't now, because that's the most competitive area. It became the focus of Precision Medicine Initiative, and NCI is a world in and of itself, outside of NIH, funding a lot of this activity. And right now we're organizing an inborn errors group to really start doing curation. And one of the things I plan to do, and I've already had initial discussions with Michelle and a few other of the regional collaboratives in states that actually do a lot of molecular testing within their laboratories, is how do we bring that kind of data into ClinGen? Because that takes us from the clinical perspective of a patient and that ascertainment bias that we have when we work with the academic medical center data, to that unbiased ascertainment of newborn screening. There's some bias in that we start with a biomarker, but based on that biomarker, we see a lot more variation than we see at the clinical level. So how do we bring the state programs that are doing more and more molecular work into that data collection activity to really begin to answer some of the penetrance questions that help us manage our patients? I've said that. I'll spare you what it takes to classify a variant. But I will show this. This really points to that problem I alluded to, which is 83% of patients have rare or uncertain significance variants. This is out of the first 5,700 or so. You can see on the left side that most patients will have one of those. 17% will have something labeled pathogenic, but it's that long tail of variants that have only been seen once or twice. The only way we're going to get to where we can actually have a firmer interpretation of whether they're pathogenic, likely or not, is going to be by getting more of those variants into the database to look at the patients that had them and what were their outcomes and conditions. ClinVar is the NCBI database where all of this is housed, and they're one of the partners in the ClinGen project. I'm not going to go through this. Hopefully you'll be able to share slides with everybody after the meeting. But there's lots and lots of groups increasingly involved in ClinGen, not just the grantees. We're increasingly feeling like we're the ones who are increasingly altruistic as we get more and more clinical groups to begin curating the information that we've built a system to collect. Quickly touch on NBSTRN as the last section. Infrastructure and resources are sort of central to the NBSTRN. We were charged with creating a virtual repository of dried blood spots. We have 4 states, 3.5 million dried blood spots that researchers can access. Nobody wants to come in now. We were supposed to bring another state in, but until we get some resolution to the common rule, I can't argue with a state that says, why would I put all this investment into joining a repository that may require me to do something I can't afford to do by consenting every patient in my state that gets newborn screening for their data to go into a database or be used in research? So we're on hold on that project for the moment. Every indication is that they want to get the common rules settled before the administration changes. Why, I'm not entirely sure. But until the NAS came out and said you didn't get this right, we thought it was going to roll. It may actually come out more diluted than not diluted than I thought it would, but hopefully it will come out soon. Longitudinal laboratory and clinical data collection was the other, because we know that as we identify patients pre-symptomatically, it's not a one-time look at whether they have the disease or not. It's a longitudinal follow-up of that patient to see how is their phenotype changing, when is it changing, when does the disease manifest, is the disease manifest, and that whole penetrance question. And then the multi-state pilots, I think, are going to be an increasing level area of activity within NBS-TRN because they are rolling out and there's a lot on the horizon. So the key resources, obviously, we're highly reliant upon patient populations and their willingness to participate. Obviously, they need to know what we're planning to do with their data. That seems to be the rate-limiting step. For the most part, almost every focus group survey type work I've seen, patient populations start with 25% saying, yeah, you can use my data, 75% no, not unless I know how. Once you are explained to them what your interest is, why you're collecting the data, it completely flips to 75% saying, yeah, I'd like my data used because of the improvement it can bring to healthcare, and 25% saying, no, you can't have my data, and 5 to 10% just being privacy crazy. So I'm going to zip through some of the components of the newborn screening system, but obviously development of new technologies that enable screening in either genomics or newborn screening are central to what we do. Being able to compare our predicate technologies to new technologies becoming available to hopefully improve screening over time and reduce cost are central. And then assessing treatments and whether they're effective or not. The virtual repository I mentioned, we use R4S, the Region 4 Stork program. While it was developed as a quality improvement tool, it actually has high utility in the in developing a newborn screening test. So this first wave of pilots that we do are really going to utilize R4S for data collection. All of the, the analytical components are there. It's just that now we're going to use it in a pilot to figure out where our cutoffs ought to be, rather than using it to improve them later. We're going to be partnering with APHL, actually, and after we, in NBS-TRN, do that first pilot, where we run 5 or 6 states and get the initial data about a new condition in newborn screening. APHL just got a grant now to do implementation in the next 15, 20, or 25 states. So we'll be partnering to improve that bridge. So data we're collecting in the initial pilots can be brought to bear on their implementation activities. The longitudinal pediatric data resource, where we're capturing all this data longitudinally. FSMA moderate, you don't want to know about FSMA, it's no fun. And I have a number of people who ensure our compliance with the Federal Information Security Management Act. We're not HIPAA, a covered entity under HIPAA, so we're obligated to meet the FSMA requirements. All of you who collect data locally from your patients and bring it to our databases are subject to HIPAA. I'll skip that. So what's our challenge now? First is to get funded so that we can continue to have fun building this system. Engaging our partners within the system and engaging the other resource centers out there in their roles in improving genetics and genomics healthcare. We'll be doing needs assessments really around a lot of the new work requirements to really see what that means, what that work requirement means in our region and how we should approach addressing it. And then aligning our work with those requirements. And it's not a problem where we don't get to cross that bridge when we get to it. As I was talking to David Flannery earlier, he does a lot of our work in telegenetics. We're not crossing that bridge when we get there. We're there, and it's time to start crossing and hopefully making it to the other side safely for both the providers and the patients. So I'll thank the NCC staff. I don't think many are here. They're wise enough to have heard me too many times to want to come listen again. But Alicia Keene is the Associate Program Director for the NCC, and I hope we'll all be working together in the future as these projects roll out. Questions?
Save questions till the end.
We'll save questions till the end.